I invite Dr. Pamela for the next topic, which is various electrophysiological studies and their application in neuro-ophthalmology.
So we've heard about some absolutely fantastic technologies this afternoon, and we're going to step back in time and talk about an older technology now and how it helps us in this era of all these really new and wonderful things. And that is the electroretinogram, electrooculogram, and the visual evoked response. Well, just let's digress for a second, because not all of us do this very much. And the electroretinogram is really a summed or masked response that's generated at the retinal pigment epithelial layer through the photoreceptor layer and mid-retina to the neurofibril layer, and so the ERG is really a mass response of all the photoreceptors that are present in the retina. And our looking at it and evaluating it depends on the relationship that's present in each eye between the rods and the cones. And there are about 130 million rods to 7 million cones, or 17-to-1 relationship between the two photoreceptors. And if we look at the functional anatomy of the back of the eye, cones are certainly packed at the macula and the fovea, and they continue in fairly good density in the retina until you get into the mid-periphery where they start to fall off. There are no rods in the macula, in the fovea macula, until you start to get out into the mid-periphery. They increase in density and get certainly are dense to the far periphery. So so there is a difference in topographical location. The other thing that's very important is that if you look here at the foveola, there's a very small area that encompasses, but cones are present all the way out to the rest of the retina to the mid-periphery. So central or 20/20 vision is not dependent or testable by looking at cone vision itself. And so if you have a lesion here at the foveola and you do an ERG looking at cone function, ERG is going to be fine. And again, mentioned to you that the rods are absent and they increase out to the periphery. So what else? So we know that. But what else can we do to look at these photoreceptors? Well, you can separate the rods and cones on the basis of their abilities. The rods are slow and they work well in a dark environment. All of you now have your rods acting at a fairly good rate. And if we look here at this ERG, this is a mass response of the eye. This is a full flash ERG. This is your A wave, which is your photoreceptor layer. And this is your B wave, which is generated through the mid-retina. And so this is a very excellent amplitude and a normal response. Cones are involved with color discrimination. They also have a high firing rate and a fast recovery rate. So they do well in a changing environment and changing light, and they do well looking at fine spatial frequency. And so this is a flicker ERG. And here we're looking at a B wave generated by a flickering light, and this is coming in at a fast rate, and it's coming in quite quickly and in a consistent amplitude. This is the most sensitive way to look at cones. You can do a single flash in a light adapted patient and look at your photoreceptor and your B wave response, and also look at cone function. And what you'll notice is that this, as an amplitude response, is much less than the mass response you get by looking at all of the rods, which are outnumbering the cones 17-to-1. What about color discrimination? Well, at the King Hollow Eye Specialist Hospital, we did color testing. We did scotopic blue and scotopic red. And we did a dim blue to look at rod function, and we did a bright red to look at cone function. And cones, because they recover quickly, will show a biphasic curve, and rods give us a one-time only response. All right, well, so now we've regressed and looked at the basics. Well, we use the ERG to look at some problems that relate to central vision that do present to us in neuro-ophthalmology. And some patients with an early cone dystrophy don't have very much that we see that's going on in the macula, or if we see something, it's a few exudates that look like they're there, and we're wondering what that means. And there are patients, young children that come in that rod monochromatism that have no cones and have 2200 vision. So our key sum is to describe whether some of these young people have a real reason for loss of central vision that's just been inapparent so far. And so this again is our normal flicker. And if you do a flicker in a patient with a cone dysfunction, then you will get an initial response because a few of those rods that are there already will kick in, but there's no cones to keep it going, and so the response falls off, in contradistinction to the nice normal response. In a rod monochromat, there'll be a rod response that looks like a nice normal response like this, but when you turn and do cone testing and look at single flash or flicker, it's flat. All right. Well, what else do you do in ERG today? Well, we do it when we're looking for diffuse retinal pigment epithelial problems. Or retinal pigment disorders and problems like that. And that is a patient that comes in, you look at the periphery of the retina, and you see some pigment changes, some bone corpuscle changes, and you're wondering, is this really an early RP? Is this just ischemia? Is this post-inflammatory? Well, the ERG can be very helpful, because if it's a dystrophy, even if the changes are nonspecific, the ERG will be flat. If it's inflammatory, it depends on how much is abnormal, whether it will be flat or not, but with inflammatory problems, the ERG looks good. And if it's ophthalmic artery occlusion, your ERG is going to be flat, and your ERG will be abnormal as well. So this is a patient who has a rather broad A wave and a low amplitude B wave, and this patient had bilateral photoreceptor problems and decreased vision, and the flicker was poor, and the single flash was poor. All right, what about central retinal artery occlusion? Well, this is a patient with a branch, and this is a patient with a central retinal artery occlusion. And does your ERG help? Well, an ERG is going to show you this loss of the surface of the retina or loss of the B wave, and the A wave will be normal, so the photoreceptors will be fine. And so if you look at here, this is a normal single flash, flicker, and scotopic response. If you have a central retinal artery occlusion, you've lost the B wave or the mid-retina and on up, so your A wave is there, but there's no B wave, and your flicker may be present if there's cilioretinal artery or if there's some maintenance of central function, but your B wave will be abnormal. And this is just progressive B wave changes with progressive ischemia. Well, this was a patient that we saw who was 50 years old, had been well, had a high triglyceride, which we found out later, and came in when her right eye was first affected, and she had a central retinal artery occlusion there. She came in about a day or two after this happened, and she was count fingers in that eye, and we could see swelling of the surface of her retina still, and we really felt there was nothing that we could do to help her at that point in time, and so we did not. But we did explain to her that timing was of the essence, and so a few days later, and this was her OCT of her left eye, and that was normal the time we first saw her. So a few days later, she came back, and she had new visual blurring in her left eye. For her then, because she came in within 4 hours of the onset of her CRAO, we gave her intraarterial TPA, and she went from hand movements in that eye to 20/20, and we have at the end, although there's some neurofibrillary loss, we have some maintenance of normal retinal function in her, and in addition to some paracentral scotomas. All right, well, does ERG help more than OCT? I don't really know, I'm not sure. But ERG tells us something different than OCT. And this was a 52-year-old male with sudden visual loss. His vision was light perception, and this is when he came in. And if you look here, look at his optic nerve. This optic nerve, and the key here is that his optic nerve was swollen, and there was central retinal artery involvement as well with a relative cherry red spot. And you can see the swell here in the red free. And on fluorescein, it really filled very slow and very late. Because he was otherwise well, and because he had some vision and had come in fairly early, we felt compelled to try to help him. But his vision was very poor. And he only came back to count fingers. This was his ERG response in the periphery. And there's the A wave, there's no B wave, as compared to the normal eye. And when we did the flicker, Here's his flicker in the normal eye, and there's some cone response that came through. And this was his single flash, which was pretty low grade, and compared to his rod response in the right eye compared to his rod response in the left. But the flicker showed us something. That's more than a count fingers flicker response. So what that told us is that the key here was not the degree of retinal involvement that he had, but the degree of optic nerve involvement that limited his recovery. And so he had an ophthalmic artery component to this with a choroidal ischemia, and that limited his recovery. But the ERG told us that we were successful in helping the retinal perfusion part. All right. Well, the next part of my task is to talk to you about multifocal ERG and when we do that. And I mentioned before that focal macular lesions don't show well on a mass response in the ERG. So we do a multifocal ERG looking at macular function to see if we can pick that out and differentiate it from the rest of function around, and then looking at the retinal function in general in different areas to see if we can discern that well. And to highlight that, let's talk about a 36-year-old woman who said she had blurred vision in one eye and had constant photopsias in that eye. They had been present for 4 days. Someone had given her a diagnosis of migraine. She didn't really have that much of a headache, and these just weren't going away. She was 20/50 in that eye and had a relative APD, and her visual field showed this enormously enlarged blind spot in that eye, and questionably enlarged in the other eye. And her retina here really was did not mirror this visual field change, and she had acquired idiopathic blind spot enlargement, or APSE. Her ERG, if we look here at the scotopic response, showed was really pretty, we did not show a clear interocular difference. When we looked at her scotopic red and blue, the scotopic response in her right eye was a little less than it was in her left, and that was certainly true for both red and blue testing. And when we looked at her flicker, the flicker in her right eye came in a tiny bit later than it did in her left, and the implicit time on a flicker is really important. So there was a very subtle cone abnormality that was occurring in her. And this is this is a published paper of a patient with APSE, and this is showing you the enlarged blind spot and the depression in the multifocal ERG around the optic nerve that mirrors that change, and the recovery that can happen to some degree as the condition resolves. All right. Well, what else? What else causes photopsias? Well, any photoreceptor degeneration can, and paraneoplastic syndromes like CAR, MAR, and cancer-associated cone dysfunction can, retinitis pigmentosa, and toxic problems. But really what we care about are the photoreceptor degenerations. And this was a patient who came in who had CAR and from a small cell CA of the lung. And his cone response in each eye was really negligible to almost negligible. But he had some vague vision that was count fingers in a small island that he could see, and we were very interested in trying to maintain that for him. This was his scotopic response, which was really quite inapparent for us. And we did an OCT on him, and he had a tiny island of vision centrally, and the OCT seems to suggest that might be truly real. But it really shows quite a loss of his photoreceptor layer and loss of his retinal nerve fiber layer as well. The vigabatrin. Well, you know, in the U.S., we're starting to use vigabatrin, which has been used a lot in Europe and perhaps here as well. And we're using it for infantile spasms or seizures in the first year of life and complex partial seizures in adults. And it was noted by an optometrist in the U.K. who had been using vigabatrin for years for complex partial seizures that it was bumping into walls all of a sudden. And so it became clear that vigabatrin does something to the ERG that is not quantitated yet, but is being looked at. So if you have a patient on vigabatrin, a baseline ERG should be done, and that should be looked at some time periodically as you follow the patients, or at least look at visual fields in the patients. What else gives us constant photopsias? Well, some viral epitheliopathies can be asymmetric and can present with constant photopsias. And this is an EOG in the dark adapted and then the light adapted state, having the patient look right and left and measuring the differences in potential between the back of the eye and the front of the eye as the patient looks from side to side, giving you a curve that's much greater when they're light adapted and the retinal pigment epithelial layer is firing like crazy. And here's the EOG in her normal eye compared to her abnormal eye where she was having a lot of photopsias. And our postulate was post-viral / autoimmune retinal pigment epitheliopathy for her, so the EOG helped with that photopsia symptom. All right, I'm going to finish with a little on pattern visual evoked responses. We do these classically for retrobulbar neuritis, and we know that the disc can look normal and the pattern visual evoked response can be slow. And we do it not when we know the patient has a retrobulbar neuritis, but when we're wondering if the other eye has a retrobulbar neuritis, so the more normal eye, and we look to see if that eye has some slowing that it should not have because we think it's normal. The other questions, though, are can we use it in other ocular disorders? And what about anterior ischemic optic neuropathy? Well, there are lots of reports that the latency can either be normal or mildly prolonged in ischemic optic neuropathy. So if it's normal, that's helpful because that will differentiate an ischemic eye from a demyelinating eye. And for some patients that come through in midlife, that's an important thing to know. Is that disc swelling ischemic or is that disc swelling inflammatory? Papilledema doesn't get central function, gets peripheral function and neurofibril layer loss peripherally. Your PVER should be normal. And functional problems should not affect the pattern visual evoked response if the patient is looking at the center of the screen and if the patient is not voluntarily blurring their eyes. So you have to tell your technicians to be sure they watch and make sure the patient's maintaining fixation. Well, this was a cadastral patient we talked about yesterday, and this was her eye with temporal pallor, and her apparently more normal eye, and she was in her mid-50s, and as she had her pattern visual evoked response done, a latency of 98, 99 milliseconds for a 30-minute check is terrific in the 50s. That's a normal response. For a 15-minute check, that's acceptable. There's no way that if this was a demyelinating optic neuropathy, her pattern VER could be that good. So an ischemic disorder or a vasculopathy that's ischemic, you can differentiate sometimes if you're lucky with a pattern visual evoked response. And this is in contradistinction to a patient with a normal PVER on one side and a flat VER on another side with an optic neuropathy, as opposed to bilateral normal PVERs from demyelinating disease in this patient. Okay, the last thing is flash VEPs. The only time they are good is if you really can't see the back of the eye and you want to know whether there's truly any light perception there. And so it's useful if there's a dense media opacity, either cataract and to some degree vitreous hemorrhage, but a really dense vitreous hemorrhage may block your flash VEP as well. What you have to remember is that the flash VEP is normal in cortical and occipital blindness, and that's essential. And the reason is here's a flash VEP, and this is showing you different areas of the brain that is being projected over. And so your flash VEP is represented so diffusely in the brain, whether it be temporal, parietal, or deep white matter, that anywhere that is transmitted to will show up as a positive flash response. Doesn't take occipital cortical integrity to show a normal flash VEP response. So that's what I wanted to tell you about and how I use electrophysiology today. Thank you.